Hey everyone, welcome back to Discussions with Dr. G. I'm Dr. G, your resident nurse with a fondness for acrylic paint and cats. Let's just say my hobbies are way less dramatic than the things your patients complain about, like pain. Today we're going to start with this topic that absolutely everyone thinks that they understand until they actually have to explain it to a patient. Now you hear pain and you think stub toe, broken bone, dentist office at 7 a.m., the classics. But medically, we've got several different types of pain. So let's look at them. Let's start with acute pain. This is your fast, sharp, body's alarm system kind of pain. Think post-surgery, that time you racked your shin into a table, or maybe you've given birth and you just wanted to apologize to your pelvic floor. Because acute pain is pretty clear-cut. It usually lasts for a few days up to a few weeks, and we thank goodness for that. Now, chronic pain, that is sneakier. It's more of a marathon running type of problem. Anything lasting more than 3 months, and we call it chronic. Aches and pains that just love to stick around, you know? They mess with your body chemistry, so you get this spike in norepinephrine and cytokines. Your nerves are partying all the time. I need you to think like arthritis, old back injuries, and even migraines, because this can become chronic too. All of this can lead to all sorts of misery. Now, let's not forget about the weird pains, like neuropathic pain, which is a nerve pain that has your nerves telling you about their bad day with burning, tingling, and shooting sensations. We have nociceptive pain, which is what you get from a good old injury like breaking your arm. It's more of a straightforward tissue kind of pain. And then we also have radicular pain, which is basically pain that radiates along the entire nerve. Think sciatica. Okay? Pain isn't just physical though. It messes with your body. It jacks up your heart rate, your blood pressure. It slows healing. It tanks your mobility, and honestly can sink you into a depression and or rob you of sleep. It racks up your healthcare bills because let's face it, people with pain see us in the hospital a lot more often. So why do we treat it? Well, because poorly managed pain isn't just about suffering in silence. If your patient's pain isn't controlled, like I said, their heart rate's going to climb, their blood pressure's going to spike, they can't sleep, their wounds heal slower, and you've got frustrated folks spiraling into anxiety or depression. Trust me, Medicare isn't going to come reward you for handing out warm blankets and calling it done. So let's slide into the world of analgesics. You might think painkillers are all the same. Pop a pill, hope for the best, right? No. We've got opioid agonists, the heavy hitters. This is your morphine, your fentanyl, your hydromorphone, and your methadone. These work by binding mu receptors in your brain, wiping out pain, but also making patients a little too relaxed sometimes. We're talking euphoria, sedation, and famously, respiratory depression. Probably not what you're shooting for unless you enjoy code blues at 3 a.m. What are the indications for opioids? Well, severe pain, myocardial infarction, cancer, even end-of-life stuff. But we have to dodge landmines. This means avoiding opioid use in people with respiratory diseases, CNS depression, bowel issues, or anyone with a sketchy liver or kidneys. And you have to watch for sedation, nausea, and constipation. And let's not forget my favorite nursing problems, hypotension, urinary retention, and of course, the risk for misuse and abuse. Now, you got to keep a close eye on your patient's breathing, oxygen levels, and for goodness sakes, know if they're opioid naive or not. This is why you always start with the lowest effective dose and work your way up. Make sure you're using a bowel regimen, and naloxone needs to be accessible. If you need a refresher on mu receptors and how they work, check out the discussion, Substance Use Disorder Meds. All right, now let's move on to opioid agonist antagonists. This is buprenorphine or butorphanol, and don't forget dual mechanism agents like tramadol. These are a slightly safer middle child style pain med, okay? They give pain relief, but with less risk for misuse. If you put them together with opioids, you're going to have a problem, so be very careful. A quick note about tramadol, it works partly as a weak opioid and partly as an SNRI, kind of like an antidepressant. This means that the extra serotonin and norepinephrine do help with the pain, but you cannot mix it with antidepressants, unless, of course, you want a front row seat to serotonin syndrome. Okay? Don't ever crush extended release tablets, unless, of course, you want to meet me in the ER for seizure protocol practice. Okay? Now, let's not forget about our opioid antagonist, naloxone, our hero, our literal lifesaver. Okay? Naloxone is the reason that people survive opioid overdoses. All right? Now, let's move on to our non-opioid analgesics like acetaminophen and NSAIDs, because let's be real, not everybody needs an opioid or even that middle child. Acetaminophen, or paracetamol if you watch British dramas, is the go-to for headaches and fevers. It works in the central nervous system, but the big caveat here is not to torch the liver. Okay, that means no more than 4 grams a day. And if your patient is a heavy drinker or has liver trouble, hands off completely. You also need to do some patient education because acetaminophen hides in other drugs. For instance, it's in most cold medicines. So you got to teach people to read labels, okay? If someone ever overdoses, it's an instant ticket for N-acetylcysteine. Okay, it is a drug name that you're probably going to forget, but I need you to remember it because it is the antidote to acetaminophen poisoning. Moving on, NSAIDs, ibuprofen, ketorolac, naproxen, celecoxib, aspirin. These guys block prostaglandins so you get less inflammation and less pain. Sounds pretty good until you see someone with a GI bleed or ulcers. They can also mess with the kidneys, and they can raise cardiovascular risk, especially those COX-2 selective ones. So anyone with peptic ulcer disease, a history of GI bleeds, or a history of serious kidney trouble, they should be taking acetaminophen instead. Moving on, local anesthetics, because not all pain needs to be bludgeoned by opioids or non-opioids. Local anesthetics like lidocaine, okay? The lidocaine specifically blocks sodium channels, so you're basically cutting pain off right at the signal highway. Obviously not as dramatic as an epidural, but it is pretty effective for, patients getting stitches or dental work. Or you can always slap a patch on their back for lower back pain. But if the drug gets into the bloodstream, watch out. The next thing you know, your patient could be seizing or tossing out heart rhythms like a DJ. Adjuvant analgesics. These are your unsung heroes, especially for neuropathic or tricky chronic pain. Antidepressants like duloxetine boost serotonin and norepinephrine, dialing down fibromyalgia or neuropathic pain. But you gotta watch out for serotonin syndrome, sedation, mood changes, weird swelling, and occasionally skin reactions that make my own skin crawl. And of course, because it's an antidepressant, you are going to taper off slowly. You're going to keep an eye on the patient's mood and make sure that they are adhering to the decreased dose regimen. Now, we have anticonvulsants like gabapentin, which is great for nerve pain. One of my patients with shingles, for example, got gabapentin to keep the burning at bay when the rash alone was driving them nuts, okay? But it's, of course, not all rainbows and unicorns. Gabapentin can cause sedation, dizziness, and, of course, dependence. The last one I want to talk about is cannabis. cannabis and CBD. These target the endocannabinoid system, and there's actually promising evidence that cannabis and CBD can help things like neuropathic pain and even spasticity and multiple sclerosis. Some studies show it can lower opioid needs for chronic pain. And I'm not saying that everyone should go start growing their own forest of hemp plants, right? But it can help. The caveat to cannabis and CBD: history of psychosis, cardiovascular strain, addiction, or weirdly, the infamous hyperemesis syndrome. Okay? There is, of course, a use for misuse that is usually occurring with that history of addiction. Guidance says to start low, go slow, avoid in patients with psychiatric issues, heart disease, or pregnancy, and keep it away from the grandkids and pets. We have to stick with what our state laws and hospital policies say as far as actual cannabis and CBD use. Nursing safety is all about solid assessment. Know your pain types, severity, how it impacts function, and how the patient is actually responding to therapy. When it comes to teaching, keep it clear, right? Take meds as prescribed. Don't double dip in the OTCs, and absolutely positively call the doc if you see black stool, jaundice, rash, or new trouble breathing. Please taper off those long-term opioids and steroids. Nobody wants to deal with a withdrawal or adrenal crisis in the ER at 2 a.m. I always tell my students, pain is more than just numbers on a scale. You recognize the cues, analyze the risks and benefits, and go for safe interventions, and always circle back to see if what you did actually worked. Now let's wrap this up, okay? Just remember, pain is never just physical. It's a psychological and social problem too. Opioids work, but they come with plenty of baggage. NSAIDs help, but love to stir up the GI drama. And acetaminophen is great in the right dose. Not too much if you're dosing like it's candy, okay? Those adjuvants, don't underestimate the power of gabapentin for nerve pain. But above all, it is the nurse who makes sense of it all, providing safe care and smart education. Thank you for tuning in. I can't wait to talk to you about even more pharmacology next time.